Welcome to the Heart of Innovation, brought to you by the Global P.A.D. Association and sponsored by Reflow Medical. This is our Save My Piggy special. It's where we share the story of a courageous person with peripheral artery disease being that poor circulation in mainly the legs that can lead to amputation if it's not treated sooner rather than later. We have Dr. John Phillips, who is here with us, my amazing co host and the creator of the Save My Piggies series. I think, Dr. John, we are going to probably jump right into this story because we have Dr. Don Tynes. He is out of Benton Harbor, Michigan, and he's an internal medicine doctor who is fighting for life and limb for patients in the Michigan area. And he is not a limb salvage specialist, meaning that he is not one of the plumbers like you, Dr. John, but he is working with limb savers across Michigan, fighting to save the limbs of his patients, including the one we're going to introduce you to today. So I want to welcome you, Dr. John, to the show. Hello, Dr. John.
How are you doing? Happy Monday. Uh,
Monday.
Monday it is. Alas,
We're
a new week. A new week has
Yes.
befallen upon us. I've already done two cases for folks with critical limb ischemia,
Wow.
and
And that's the most advanced stage of PAD.
indeed
That's
it is.
when the limb is on the line.
It is. And unfortunately, one of the gentlemen, he's already lost all his toes, so he's missing his piggies, but we're going to preserve the limb for him, which makes it functional so he can still ambulate. So these are, and I know we're going to speak with Elizabeth and Dr. Tynes, and these folks have chronic disease that it's kind of like going to the dentist. I tell people, like, we open it up and then you're gonna have to come back to get a little touch up. And as long as you want to fight for your leg and fight for your life, we'll fight with you. And that sounds like that's the story we're gonna hear. So I'm excited. Let's jump into this. Save my piggies.
Yeah, welcome, Reverend Dr. Don Times. Thank you so much for being here. Really, really appreciate it. You can go ahead and unmute and we'll get you chiming in here and sharing the story, and then we'll let you introduce Elizabeth and her story. Good to
Yeah,
have you here.
yeah, thank you, thank you, thank you. And this is such important. I started this journey in 2011. 2011, one of my former um, interns, who I was a chief of, Dr. Maher Elder, had went and specialized in the cardiology and then became an interventionalist, and then wind up specializing in below the knee angioplasty, and actually became a national leader in Michigan doing this procedure. Um, where I was located on the other side of the state, um, I didn't have access. And we were reunited because I was interacting with a doctor named Dr. Kim Williams, um, who was the president of the ABC American Black Cardiology and President Obama's cardiologist. And I was driving and working with him in Chicago, and he was also working at Wayne State. And when I became aware that this procedure was now perfected, uh, I started taking 7 patients a week down to Detroit. And lo and behold, within a year, I had made a trip and we had took 100 patients.
Mm.
And and then we, recognized, and then we started the Save the Leg program to let people know that you don't need to be amputated. And so I'm an anti-amputation specialist, and I work with you guys to find the patients. And back then, in 2011, all I had was physical diagnosis skills. I didn't have the Doppler and the eye and all that stuff back then, but we were successful. I actually have one of my earlier patients, Deacon Willie Murphy, actually in the office as well, who we've made those trips in the winter storm to make sure that people didn't lose their limbs. Because what I found was that meeting with the hospital administrators, that down in Detroit, they were accepting doing the procedure because CMS was reimbursing at 14,000 for the procedure. But where I was located at, in Southwest Michigan, the hospital gets reimbursed $75,000 if it's just a toe or a TAM or a half a foot or a BKA or an AKA. And there were some incidents that one patient had subsequent procedures. So they got one patient gave 75,000 for a toe. Then they got 75,000 and came back for and did a TAM. Then they came back 75,000, did a BKA. Then came back 75,000, did an AKA. And
Wow.
and I was highly upset, and I made it my mission to fight the insurance companies and protect the patients. And as a result, I had to become a person who was considered kind of radical because I said that I was pro-patient. Our first love is the patients, and that's what we've lost. And that's why I'm so glad that you guys have together, because that's showing the first love is the love for the patient, not love for CEO, not love for hospitals. But this is the calling that we have, that we are brought in to do this. And that's why I made this trip every Wednesday down to the Detroit Medical Center. And I stayed overnight with the patients. And once they were cleared, and I brought them back at no charge because I'm a medical missionary. And what we did over that period of time, we prevented 300 amputations um, from 2011 to 2015 or 71. We do look, and now I'm going to ramp up the numbers by now working with Dr. Allen in Battle Creek, which is actually closer, because transportation is a major, major issue.
It is.
And the grandchildren and the people here did not have um, reliable transportation enough to make that trip. And
Yeah.
so Mother Elizabeth Simmons went down with their Deacon William Deacon Murphy went down there. And what was a blessing with Deacon Murphy here is that I was able to have them look at his heart, and we found out that he was having coronary spasms. And so I was able to treat that as well as keep his legs and his heart together. Mhm.
I think that's it's so incredible. I mean, here you are, an internal medicine doctor, and you're literally shuttling your patients around. You're saying, "Hey, there's something serious going on here. I want to make sure you have the best care. I'm going to round you all up, get you diagnosed, and we're going to drive you wherever you need to get the most advanced life and limb-saving care." Which is absolutely incredible, because not every area, right, Dr. John? Not every area has the most advanced tools and techniques. It takes a while. Innovation is moving at the speed of light when it comes to limb salvage, and it's slow to roll, right?
What I have to say to that is number one, that people have to realize that most hospitals are community hospitals, and unless you're close to a university complex, you're not going to receive that type of care. Or unless specialists that come out in interventional cardiology, endovascular surgery, come out close to that community, you're not going to receive that care. And our role as a physician is to treat disease by any means necessary and make sure that they get to that adequate care. And so what happens is, I say this phrase, people wind up staying close to the cemetery, and then there's people who don't mind traveling a distance to have a long life. And so we have to, over time, close that gap of distance between receiving this type of care, but at the same time, that the hospital CEOs and administrators don't see it as a viable investment. So we as physicians want to become outliers because the hospitals here felt that I robbed them of $3 million by the patients that I took down to Detroit, but the patients still have their feet and their toes. And
Which
so
is the
real
most
physicians,
important. And coming
yeah,
up right
and
here on the
correct.
Heart of Innovation, we're going to hear how the hospitals came up with that $3 million number that they lost when Dr. Tynes brought these patients to another facility to save their legs, all of their digits, all of the above, versus having them taken away. So stay with us. Don't go away right here on KDOW.
How many procedures are you willing to go through? Is it worth going through that many, or would you rather just step aside? amputation should absolutely, positively, 100% never be a first-line treatment.
What an incredible operation, what an incredible lab you have here.
Without a doubt, we're underdiagnosing peripheral arterial disease. It has not gotten the attention that it should because it is a killing disease, it is a disabling disease, and most importantly, it's a disease that we now have great treatments for.
Okay, let's go to the next one.
They were going to amputate it, and I needed to consult with my family. Did I want it off here or here? You're just shocked. It's scary. I don't even know how to explain it. You're 42 years old.
We're waiting till people are at the end of the spectrum and almost beyond hope. There is good care available here. Closed minds are what we have to get rid of.
Welcome back, everybody. Thanks for joining us. We are continuing our conversation with Dr. Tynes, who I think adds a new twist to the term house calls, where in fact, doctor, you're actually taking these folks. Are you physically driving them to these places in Detroit? And if so, clearly you're going above and beyond the call. And I was just talking to another physician about being a doctor and how it is a calling, and it's not shift work, and you have to have your phone on. But I know we need to talk to Miss Elizabeth. But tell me, what is it about the fact that you're so committed to these patients that you're willing to drive them to a facility to get them treated? Where does this motivation come from?
The trip is a 200-mile trip down from where we're at back, so it's a 400-mile trip. But it's not a trip when you think of that you was given this gift, this special calling to be able to help and to heal patients. And if you don't have an ego, what you can't do, you take it to someone else who can do. So the fact that if we are physicians and, we are physicians and we see there's a need and there's a therapy, it is by our craft, it is by our calling that we must, as an imperative, do everything possible for our patients. And that's is how I saw medicine. That's how when I look at the early doctors, you can go all the way in ancient times, Imhotep, Peshet, and Ray. But then when you come up, you got the brilliant guy studying on the island of Kos in Greece, Hippocrates, translating the Egyptian Meta Nature into Greek. You've got the our great physicians, Sir William Osler. So when you look at these individuals that who go above and beyond, that was who we were. We didn't have a business aspect to medicine, so I didn't even know that I was doing anything unusual. All I knew that in a community-based area that they don't have the expertise and that the family members did not economically have the means to get the patients to where they needed. And me as a physician with a reliable car, my wife's van, that could house 7 patients, it was like, okay, I do a half day on Wednesday, get on the highway, get them to the hospital, have them get the procedure, verify there's a blockage there. We had like a 98% blockage rate. They would angioplast. Then we would come back a few times. They had to redo the procedure due to the anatomy. But, and then, that was just something that felt natural and was natural. But I don't know. But also, I'm a medical missionary. So that might be the difference.
I still think that there's a lot of ignorance out in the community, and I think that people are just repeating
Amen.
what they hear in the media. And when I posted the promotion for you being on and that you were a limb saver and what you were doing to save limbs, this gentleman jumps on immediately and has to, plug in there that I'm going to be watching because so many people are doing too many procedures to save limbs that are leading to amputations, and too many procedures too soon are leading to all these amputations. And I had to kindly say, hey, whoa, step back. That's not the big problem here. Yes, there is a problem with that. But what we're talking about here, and what I find is the biggest problem, is that more than 60% of these amputations that are occurring are not because people are treating too soon. It's because they're either treating too late or they're not treating at all. They're not even trying. And 90% of which are literally the patient, they're not even getting a vascular evaluation at all. And so, in your situation, in your area, that's what you were seeing. You were seeing that these patients were not getting diagnosed soon enough. And when they were finally being diagnosed, the frontline treatment at your local facilities was amputation. And you said, whoa, there has to be something better than this for my patients to improve their prognosis, improve their quality of life in the meantime. Correct?
You're 100% correct. I'm gonna tell you this. All the patients that I took down to down to the other state down in Detroit, all have been slated for amputation. And not only that, that I had to do that because there were patients who could have not been amputated, but it was the I gotta say crime. The crime was that there were patients who needed aggressive wound care, who needed walking programs, who needed to be on some antiplatelet therapies, and that was not being done because Medicare accidentally incentivized amputation. $75,000 for an amputation, $14,000 for angioplasty to restore circulation. And amputation does not restore circulation. Amputation does not restore circulation. And the vascular surgeons of that day were trying to dissuade me from doing the angioplasty on these patients, saying that eventually that they're going to need amputations anyway. So why bother? And I told them that if you if you do a bypass, how long does the bypass last? And then once the bypass is done, what else do you have? So I said the delay to a bypass gives that patient's longevity and time and also develop collateral circulation to help to prevent the eventual annihilation of that limb. And so the surgeons were looking out for their money, where I told them that they should also do angioplasty so that way they can keep that leg longer. And then once it's been exhausted, then it should be. Surgery has always been taught as a last resort. Now we have endovascular surgery and new techniques coming forward. So I had to battle the cardiologists, I had to battle the hospitals, and I'm still a pariah because I do not let my patients get amputated because the mindset is still old. Even when I took a patient who they said there was no way to save that patient's leg, they the hospital fought me down in that area. That was a different hospital, but we did the procedure. Patient still has that leg, and that's about 6 years, 7 years ago. They're still walking. I just saw the patient last week. So our medical mindset is behind. We have to start looking at preservation. That, you know, preservation and amputation now has a parallel of, instead of trying to put a patient on uh, four-pillar therapy, guideline therapy, we're telling hospice and palliative care instead of we trying to do the expensive care. They're
Yeah.
telling us this care is too expensive, so we need to do hospice and palliative care. That's not real physicians. That's business in impersonating physicians.
I do want to clear a couple things up. Number one, when it comes to bypass surgery, there is a time and place for it. And also, we do have issues with some doctors that jail the entire leg and don't leave a landing zone for surgeries. And that's a major issue as well. And so, every single person that, when you do an angioplasty, if that is the chosen method and you feel it's the best method, they do need to always keep in mind the opportunity for surgical options and leaving those landing zones for potential bypass in the future. But number two is for those watching that say, wait a minute, you could kill someone by saying that, no amputation, but you're not saying that. You actually are a smart guy. You know if someone needs an amputation.
Let me tell you, okay, so I'm gonna have to tell you the truth. I have seen when I reviewed the notes and I cross-referenced the MRI report and the biopsy reports, there was no osteomyelitis. And the injury was too fresh to even allow that time. And there was no periosteal elevation on the x-rays, but yet there was amputation. So I didn't want to go there, but no. So these people pushing back, no. If the CDC would come in and look at these amputations like they looked at the OB department and finding that over 85% of the maternal deaths and infant deaths were preventable, then we can see a whole different picture if they're under the microscope and looking at these amputations. So they need to be very careful on the they tread.
And coming up right here on the Heart of Innovation, we're going to meet one of his patients and a real tough case that he's had to contend with just in the last month or so. So stay with us right here on KDOW. Don't go away. You don't want to miss this story.
Your type of condition is called critical limb ischemia. It's the most advanced form of P.A.D. or peripheral arterial disease.
Every 4 minutes, there is an amputation in this country due to P.A.D. and diabetes. We also know that 85% of these amputations are preventable with early intervention.
It's a flip of the coin. Patient prognosis is tied to whether or not they are referred to a true expert in the management of peripheral arterial disease.
Do you know if your physician is an experienced CLI operator?
When you're in the hospital dealing with doctors and stuff, you figure they know what they're talking about.
The skill level varies doctor from doctor and hospital to hospital.
Patients with limb threat are in constant fear. The depression that someone experiences after they lose a limb is equivalent to those of losing their spouse of 40 years.
I was stuck in a wheelchair close to 2 years and my husband had to quit work.
I didn't know what to do at this point because we had had nothing but infections and hospital stays and infections and hospital stays.
And they took one toe, another toe, and then it was another toe, and then half his foot before he was even diagnosed with P.A.D.
And all I heard was, "What are we doing here? Just cut it off." And I pulled the curtain back like, "Are you kidding me?"
Do you really want to go through all that?
That's crazy. That's insane.
The protocol is to send them to amputation. Always, always, always get multiple opinions.
We do have options.
We need to listen more to our patients.
If you're going to chop off their leg anyway, why not just let someone else try?
This is the progression. First comes the wounds, and then comes an amputation. And I wasn't going to accept that.
So that's what it's like to try to save a leg.
Welcome back, everybody. Thanks for joining us. Very special Save My Piggy episode. We're speaking with Dr. Tynes regarding his commitment to saving the piggies. And we'd like to welcome Miss Elizabeth to the show. Elizabeth, you are one of Dr. Tynes' patients. Is that correct? And he has been working to help save your piggies as well.
Yes.
All right. Tell us your story, please. How'd you guys meet?
I met him probably 40 years ago, or when he first started practicing here in Benton Harbor. Mm-hmm. And he started the Save the Leg program with me probably 9-10 years ago. At first he gave me a cane. He saw me holding the pew at church, and he made me make an appointment to see him. And then he took me to Detroit on 3 different occasions.
You met Dr. Tynes several years ago. He astutely, I think it sounds like, figured out that you had peripheral arterial disease, so blockages in those leg arteries, and got you down to a facility that could help get you some better blood flow. And along the way, sounds like you need to go on dialysis. So had issues with the kidneys, which is a significant risk factor for developing blockages in the arteries, particularly below the knee, which are very difficult to treat and lead to a tremendous amount of minor amputations and then, unfortunately, major amputations. But along this process, just can you share with us from a patient's perspective the amount of dedication that Dr. Tynes has to you? Because I don't know of any. We're not really even allowed to drive our patients from my clinic, which is like 3 blocks away, to the hospital. Medical, legal issues, things of that nature. You've got a physician now that's driving you, it sounds like, back and forth, 200 plus miles. That's a heck of a lot of commitment. What does that mean to you and the community at large that you've got somebody fighting for you that hard?
It means a lot to me, because had he not been in my corner, I probably would have been dead a long time ago. And I say that sincerely, because I could go to him, and whether I had a check in my hand or not, he was going to see me. That was never an issue. And whatever, if I called and said I needed something at home, he made sure I got it.
We're talking about a period starting in 2011 and to a period of going to 2024. So what's important about that, based on Dr. Phillips, is that the patients who in my program have been able to be stabilized without amputation from 2011 to 2024, and without needing to undergo the bypass surgery. So what happened? So from 2011 to 2025, 2024, that would have been a needless amputation. So what wound up happening, she came by the office and actually said, ooh, I kind of messed up. I didn't let you know, but they told me that my toe was a little bit dusky. And we had actually planned for her to go to Detroit. But the truth of the matter is, if people know that they are a saber-leg patient, they do not correspond with me in terms of communicate with the primary care physician about their patient. So what happens is that in this particular case, she made them aware she was a saber-leg patient. Then what happened is she only wanted some medication for pain, because we were scheduling her to go to get angioplasty to restore circulation. What wind up happening was that it was accidentally noted that the community called the office, and my staff saw that she was in the hospital and that they had planned to amputate the wrong foot.
So she did end up in the hospital anyway. So even though they knew she was a save-a-leg patient, she somehow ended up, probably the dialysis center, brought her in, and
no, exactly what happened is that she wind up going after hours to the ER for pain medicine to hold her over till she can make her clinic appointment, and they made it an emergency. And then there was a nursing error. Her toe was on the left foot. The operation was scheduled for the right foot. And because of that, I was able to call and to stop them from trying to do an operation on the right foot and delay the surgery. And then what she was supposed to tell you, what happened, Mother Simmons, if you can remember what happened next, after the surgery was delayed, can you tell them what happened?
They took off one toe one day, one toe the next day, and the third day took off the leg.
Well, actually,
and I
yeah.
had and even today it concerns me who signed for it, because if I was mentally incompetent, who signed for it? My husband said he didn't. My kids don't live here, so I still haven't found out who said cut my leg off.
So basically, what my understanding of what happened is, so she ends up learning about this toe at the dialysis center. She goes outpatient, sees Dr. Tynes. Dr. Tynes says, "Okay, we're going to plan for you to go to Detroit to have angioplasty again." And in the meantime, she says, "I'm in so much pain." Goes to the emergency room, just hoping to get some meds just to tie her over. And I hear this over and over again. So she goes to the hospital. They admit the patient. not just, offer the meds, but admit the patient, probably seeing maybe there's an infection in there, thinking the toe looks bad. And they actually had a mishap where they targeted the wrong toe, even on the wrong foot. Dr. Tynes gets involved, says, whoa, wait a minute, delay it. That's the wrong foot. You guys got to have the right foot.
But
And coming up right here on the Heart of Innovation, we're going to hear more of Elizabeth's story and also continue to talk with Dr. Tynes about this unconscionable situation. I mean, unfortunate maybe is a better word. So stay with us right here on KDOW. Don't go away.
Walking down the street, feel the birds at in. Simple strolls turning into fights within. Don't ignore the signs, your body's playing loud. Time to act now, stand up and be proud. Peripheral artery disease is more than just an ache. It's your heart's message, don't let it take a break. Seek the help you need, your life's worth the fight. With awareness and care, we'll make it right.
Welcome back, everybody. Elizabeth, a harrowing story that you're sharing with us. And again, I think it raises concerns on a number of levels about, a patient's ability to consent for procedure, some of the confusion that can come about during a hospitalization regarding an infection and or need for surgery or procedures. So if you lost the leg ultimately, is that correct? That's correct, right?
Correct.
And Dr. Tynes has been in your corner the whole time, and he was trying to help navigate this system. I have to ask, I mean, if we're raising concerns about surgery on the wrong toe initially, but ultimately potentially some procedures that led to the complications that led to the loss of the limb, what were your interactions with the physicians in this hospital regarding these kind of perceived mishaps or these mishaps? And I guess my question is, what were their comments in terms of, how do we let this happen, or what is this treatment plan that seems so backwards?
Actually, they haven't said a whole lot to me about it. I had like 14 doctors, and I don't know how many nurses, and they've never really discussed it with me. Nobody.
And Dr. Tynes, were you in communication with the physicians?
So,
with the
go ahead, Mother.
One did tell me if they hadn't removed my leg when they did, I would have been dead. And that's all he said.
Okay, what happened once the identified mishap and the corrective medical records happened, I was able to delay the surgery with the goal of getting her discharged to get her down to the appropriate facility. What wind up happening, the MRI report came back, showed no osteo. So we had no time, so we didn't have the infection. So the person there decided that they were going to try to do the procedure that was done in Detroit. Because they had the wrong information, they went in on the wrong limb. And going in, they went on the left side. Normally we'll go on the opposite side you're going to work on. Then they found out that the records were not correct. He should have went on the right side to do the angioplasty on the left, and then tried to attempt to be on the left side and angioplast below, and the limb went ischemic. And then they did an emergent BKA, below the knee amputation. And then afterwards, the solution, which highly upset me was to consider palliative care or hospice. That was the treatment option that was being weighed. And what at that time I had to call the hospital to shut down all pain medication so that I could speak to the patient because she was so sedated.
I'm just blown away that so was your husband making decisions for you? Were they consulting with your husband during this entire
No, they
process to
weren't.
make the decision? Oh, so they weren't even checking
No,
in with your husband as to what care was being performed and to make sure that consents were signed.
no. Because the morning of the last surgery, I do remember the doctor saying, I need your signature. And when I really came to myself, I felt that was unfair
So they
because
might
I
have
was
been
not in
coming
any
to
condition.
you. They might have been coming to you all along while you were sedated, didn't know what you were doing, didn't have the right cognitive ability in that moment, but you might have been signing along the way, not realizing you were
Right.
doing it because you weren't really, oh, that's interesting. Okay. So then when you finally it came to, then that was the issue. And I'm curious, Dr. Tynes, if you've reviewed the records to find out, I mean, when they went into the leg, was it just that, it went ischemic? Was it something, was there just a shower of clots that just, they poked the beehive and it just showered clots down her leg?
This is my second patient that this happened to. She's not the only one. The other one is deceased. That's why she's not on the program tonight. What happened was a complication of that procedure, and I told you the solution. And the signature for the amputation is not Mrs. Simmons, and it's not her husband. So, you're asking detailed questions, so I'm a pastor, I'm not going to lie. And the desperation, that happened, was the issue. And the husband came to me. All my patients, I tell them not to sign anything unless they call me and I'm on speakerphone, because from the patient, Mrs. Strong, who passed away, they
Whoops, I think that
narcotics, and she
yeah.
and she was just there for pain. And when she woke up, her leg was gone. They came in while she called me that her leg was missing.
Yeah, and that's scary. I mean, a lot of times before these procedures, though, I think Dr. John would attest that you do kind of sign your life away. And if there is something that if there's a complication that occurs during a procedure and it's either your life or your limb, they have the right at that point to say to take your leg because you will have signed it beforehand. We always tell patients, hey, if you go into the procedure, no matter what, if it's not your life on the line, um, and you have some time to make sure you don't need to sign it, because if your life is on the line, whether you sign the consent form or not, they're going to take your leg if it's between your leg and your life.
That
Well,
was
they
not
said
the case.
the one doctor told me it was my life.
Mhm.
Yeah.
The record showed no osteomyelitis. It just showed I think a posterior tibial artery occlusion that would probably have been amenable to angioplasty. And but what happened, and it was I think the person was trying, but see, my whole thing is that the pressure placed on the surgeon who tried to this canceled operation to try to salvage a procedure to not lose some of the money,
Yeah.
caused this accidental uh, severing of the artery, ischemic leg, and knee for amputation. And then the thing that you have to listen is that the solution to the complication was amputation and the direction of
Oh, I'm
hospice
sorry.
and palliative care. hospice and palliative care. And that's where I had to monitor and supervise. The goal before the surgery, before they even attempted to do this, was that the patient was slated to, I was requesting discharge so that the patient could go to down to the Detroit area. The patient was stable enough to go. And this is not the first case. I have other cases like this.
Yeah,
But
I think that that's more the issue, that here you are, you're the one who's the general supervising physician. And I think that this is where you had the issue. The patient was stable at the time. They didn't need to try the procedure themselves. The patient didn't have a life-threatening infection at that point. They could have discharged for her to have the second opinion, but because she didn't have the wherewithal, she didn't have the cognitive ability because she was so sedated, they were going to her, asking her to make those decisions, and she couldn't make those decisions because she wasn't in the presence of mind. You're sitting here saying, I'm trying to advocate for her, but they're going straight to her, even though she's not, straight in her head in the moment, too medicated. And there's just this battle. So they just kept her there. And I have had situations like this with patients. And if we didn't get involved, they would have ended up without a leg too. But coming up right here on the Heart of Innovation, I want to hear some final thoughts from Dr. John. He's been sitting there very patiently. And we'll get some final thoughts from Dr. Tynes as well as Elizabeth. So don't go away. Stay with us right here on KDOW and a very special Save My Piggies episode of the Heart of Innovation. You have a short amount of time with these patients. You're the physician, I'm the patient. Explain to me, I need to walk.
I say to the patient, there's data out there that shows that in a patient who is a claudicant, which is just a fancy Latin way of saying it hurts when I walk, if we go in there and we intervene on you, you fall into a different bucket. And we know from a lot of data that patients who get unnecessary interventions for something that they could have dealt with by just walking have a higher rate of bad outcomes, including amputation. So what's our job here? We want to keep your legs virgin territory. We do not want to get in there and start rotoring and sticking stents in there and balloons in there if we don't have to. That would be crazy. It's like taking a person who's perfectly well shaped and doing liposuction on them unnecessarily. Someday when they may actually want it or need it, you've now created all this scar and caused all this trouble that procedure may not go as well as you want it to. It's a silly example, but that's the way I say it to people. So people get it. Yeah, okay, I get it. It's an unnecessary procedure at this point. Then I tell them, you can take care of this problem by yourself. And not only that, if you take care of this problem, you do the walking program and you create those collaterals, guess what? Those guys are with you for life. If I go in there and I rotor through something and I balloon it open, you're going to get maybe a year, maybe 2 years out of it. And then I have to come back and then come back again for another touch-up and another touch-up. But if you build those collaterals, you've now built things that are going to allow you to get that blood flow forever. And the vascular system is all connected. So you're also going to be benefiting your heart and your carotid arteries that deal with the stroke risk side of things. So overall, your chance of death from heart attack, from stroke, and the pain in your legs, we can make vanish by you doing this walking program. So now they're interested. Now I got them on the line. Then I say, it's easy. This is what you need to do for me. I need you to go home, and for the next 5 days, every day, I want 30 minutes of walking. And they say, what, 30 minutes? I can't even do 2 minutes without the pain. I say, I know. I'm not telling you to do 2 minutes. What I'm telling you to do is, over the course of 30 minutes, I want you to start walking. When you feel the pain, I want you to keep walking. And then I only want you to stop when you have tears in your eyes from the pain. And they laugh. And I say, but you get what I mean, right? And they get it. And then I say, then I want you to only rest for as long as you need to start up again. So I don't care in 30 minutes if you start and stop 500 times or if you walk a full 30 minutes. I just want you to do 30 minutes where you've really pushed yourself. And I want you to document, this is the key, how long you walk before the pain starts, how far you can walk once you have the pain, and then how long you need to rest before you get up and walk again. And if you document this, what you will find is patients will get really excited because within the first week, they'll already start to see their times increase. Oh, it's taking longer for the pain to set in. Ooh, that means it's working. And then they get motivated. The same way you'd step on a scale if you were trying to lose weight and you saw you lost 5 pounds from eating salads. Wow, you can do another week of it. And that's what I tell my patients. And then I tell them, Very rarely in medicine, very rarely, can I give you a guarantee on anything. But on this thing, I can guarantee you, if you don't smoke, okay, if you take your aspirin and your statin, and if you do this walking program the way I just described it to you, I guarantee you results. Why? Because multiple randomized controlled trials, which are the most powerful data trials that you can do, have come out that have clearly showed that for intermittent claudicants, again, which is people who have pain when they walk, if they do a supervised exercise therapy program, which is what this is called, a SET program, they do get a longer period of time where they walk before the pain sets in. Are you going to run the Olympics? Probably not, but you don't need to. What I try to tell them is, what I'm trying to do for you is I want to get to the point in your life when you get to go outside to the movies with your grandkids, whatever you want to do, and your legs are not on your mind. If that's the case, we've won. And that's what I'm trying to do. And they love it, and they go for it.
Welcome back, everybody. I'm trying to digest this story and unpack, and I'm looking at my mug, my Save My Piggies mug, and we have the Your Life, Your Limb, Your Story, and Elizabeth certainly telling her story, as is Dr. Tynes telling his story that includes Elizabeth. For me, I'm just trying to understand, how in 2025 now that these things still happen. And I'd like to think that most physicians, not all, but most, are trying to do what's right for their patient. Some physicians, and I've seen it, they get ahead of their skis a little bit with respect to their ability to do a certain procedure, at least in the sandbox I play in. And we see that. And we see complications. Honestly, I can't remember the last time I saw somebody have a complication where the limb was so acutely threatened that there was nothing that was salvageable. So, man, that must have been a heck of a complication. And obviously, they're going to do what they have to do to save your life, Elizabeth, at the necessity of taking the leg. I mean, I think it's a cautionary tale for having yourself in a situation where you need to have people advocating for you, whether it's family members or a physician like Dr. Tynes, or what Kim does, but you have to be around people that are going to fight for you when you can't fight for yourself, and that's what we talk about here. And it's a tragic story, but I think there are lessons to take out of it, and that's one of them. Don't accept a certain answer, whether it's amputation or this type of procedure. Get a second opinion. Get people in your corner that can help you when you are against the ropes and can't maybe help yourself. And then, you're lucky to have a doctor like Dr. Tynes. There aren't too many Dr. Tynes out there. So, lean on him, because he's certainly helping you. And I hope you've got the other leg correct. So at least we got to work to preserve that one for many, many years to come.
We have 30 seconds left. Final thoughts?
My final thoughts is that every patient with PAD needs to be tied in with global PAD, and that should be the mantra of any primary care physician trying to work the vascular area in terms of the senior citizen population, the high-risk population, which does not have to have diabetes or dialysis, but we need to have advocates like Global PAD to step in for me, because her husband kept coming, her families, and that's what allowed me to come in, because they did not want to include me. So that's why it's so important, Kim, that you be included in helping us physicians when we're busy trying to protect the other patients.
Yeah, thank you so much. Dr. Tynes, we really appreciate all you do and your fight, your passion to save limbs throughout Michigan, and the extent to which you go to try and save those piggies. And Elizabeth, we're here for you. Dr. Tynes is here for you. We're going to continue to fight alongside you. And thank you so much for your courage to share your story. And hopefully so many people will learn from your story, and their piggies will be saved as well.